amazing Australians and the story of their lives. You're tuned to Lots to Chat About with Rosemary Peterswald.
Hello and welcome, listeners. My guest today is Charles Gilt, an international public health specialist, clinical academic and global health advocate. He was Dean of the School of Public Health at the University of Queensland and is the first Queensland professorial chair in blood-borne viruses and sexually transmitted infections. He is also Emeritus Professor of Global Public Health. He is at the forefront of the treatment of AIDS worldwide. Welcome, Charles.
Well, thanks very much, Rosemary. Good day, everybody. And I just have to qualify it by saying I've only been an Australian since 2018, because as your listeners will be able to hear, I am actually originally English. And as I know, your program is called Eminent Australians. So I just thought I'd qualify that.
Oh, fair enough. Actually, we're going to come to that, Charles.
Oh,
yes,
okay, right.
Do tell us where you grew up, and we'll go on then a little bit later to discover how you got an interest in the particular field that you're in. But tell us about your childhood in England.
Well, as I said, you can tell from my accent, I'm from the UK originally. I'm a Londoner, and I studied medicine in the UK and then decided to specialise in tropical medicine and infectious diseases, because I'd always, since a young child, wanted to see the world. Yes. And that wasn't as a tourist. It was as somebody who could provide value and use to the countries where I wanted to go and live and work in. Oh. So I studied tropical medicine, and I'm actually quite a dinosaur. I qualified in medicine, and I studied in Cambridge and then in London at University College Hospital. I actually qualified in 1979, which was before the AIDS problem had been first identified.
Okay, we'll come to that in a little bit later,
yes, we will.
If that's okay.
Yep.
First of all, tell me, but you graduated in politics from Cambridge. So there's a big step, isn't there, from politics into the medical field. So just tell us a little bit more about, as I say, growing up and your studying at the university there.
I studied medicine at the University of Cambridge, and in those days, what was called preclinical medicine, which was the studies you did before you went onto the wards and in the hospital to learn the art of practicing medicine, it was 2 years. And at Cambridge, you were offered the opportunity to do any degree you wanted for the third year of what was called tripos. Right. So I elected to do political sciences, social and political sciences, which was around one of the reasons why I was interested in global health and tropical medicine, because I already had a sense of social justice and I was quite political at that time as well. So that degree suited me very well. And the other reason is that, like today, if you are going to aim to be a doctor, you really get streamed very, very early on at school to the exclusion of any arts subjects, and you focusing on all the science subjects that you need to do well in to then get admitted to medical school.
It sounds as though one would complement the other quite a bit, actually.
Well, for me, it complemented what I wanted to focus on in my career.
Particularly in the countries that you do go on, because you started on care, support and treatment of HIV and AIDS in 1988 in East Africa, based at Kenya Medical Research Institute in Nairobi. Now, this must have been both challenging and rewarding, Charles.
It was very interesting and very rewarding, because I had originally expected to work in tropical medicine on malaria, which is why I did a PhD in Oxford. But it was during that time in Oxford that it was clear that AIDS, HIV infection, that's the virus which causes AIDS, was sweeping across East Africa and causing terrible problems, which is why, combining tropical medicine and AIDS, I was sent out from Oxford on a research program to set up a team in Nairobi to look at the interaction between HIV infection and malaria.
All right.
Because HIV infection, the human immunodeficiency virus, makes you sick by destroying slowly the immune system. And the idea was that we would use infection with HIV as some sort of mechanism, a natural infection which was unraveling a particular part of the immune system, to see how that interacted with the immunity that many people built up against malaria.
Right, because malaria is one of the biggest killers worldwide, isn't it? Now, in many countries, there has, like particularly, which we'll come to later in Papua New Guinea, where you and I both lived,
Yep.
we, of course, took anti-malarial tablets, as you still do to this day. But in a number of countries, particularly in Africa, it's a huge problem still, isn't it, Charles?
Malaria is a huge problem, although great strides have been made now in
Yes.
controlling malaria. Malaria is a problem, particularly in those countries where it is highly transmitted. It is a problem for children. They get exposed to malaria and then they either die or they survive, and they have numerous infections, and then they become immune, or, as I said, you die from malaria.
Yes.
So you build up that immunity, and then the idea of the work I was going to try and focus on in Nairobi was to look at how the infection with HIV destroyed a bit of the immune system, and how that may give some insights into immunity against malaria. And that would then hopefully help contribute to working towards a malaria vaccine. So unfortunately, when I got to Nairobi, it was very, very clear that, and this is where my social justice comes out, I found it really impossible to focus on that sort of scientific, that immunological interaction, without first trying to do something about the devastation that HIV infection and AIDS was causing on the hospital system and on the healthcare system.
Yes.
Because when I went out to Nairobi, we went there in 1988, Marina, my wife, and my young child. AIDS wasn't supposed to exist in Kenya. And famously, the president of Kenya at the time, President Moi, said that there was no AIDS in Kenya, and if there was any AIDS, it was only because it had been brought in by those filthy, degenerate North Americans and their awful practices.
Right.
And this was very interesting, because I was actually working in the Kenya Medical Research Institute based in Nairobi.
Yes.
And it was very, very clear from the work I was doing in the Kenyatta National Hospital, the main hospital,
Yes.
referral hospital in Nairobi, in Kenya, that one in five of the adults who were coming in sick and being admitted as emergencies to the hospital were infected with HIV. Right. 1 in 5.
That's a huge amount, isn't it?
And actually, there were certain populations that were highly infected with HIV, and that the general prevalence in the adult population then was around 5%. So I shouldn't get too political, but to criticise the president of Kenya for saying it didn't exist in this country was really quite difficult. And I was nearly, I nearly had to stop my work on AIDS because the president said it didn't exist. Right. And that meant I nearly had to go back to Oxford.
Yes. It's not extraordinary. So he just didn't open his eyes to it. And, of course, it wasn't just in Africa. It was spreading around the world, wasn't it?
Yes, it had originally started in Africa because the human immunodeficiency virus, HIV, originally started in monkeys and in chimpanzees, and it crossed the species barrier in the 20s and 30s and 40s in Central Africa.
Right.
And so the chimpanzee virus was able to infect humans. So this was the start of the AIDS problem. And slowly, HIV spread amongst populations in the Congo and Cameroon and in West Africa. And then with colonization and people living in cities and a large change in populations, the virus then became epidemic.
Yes.
And it was taken from West Africa to the Caribbean,
Right.
probably by people who were Haitian troops who were working for the UN in West Africa. And they went back to Haiti and they managed to spread a little bit of HIV there. Right. And then there was all sorts of And then for a variety of reasons, it
Yes.
took off in Haiti, and then American male tourists flew down to Haiti for sex holidays.
Right.
And then it moved from being a problem that was heterosexual,
Yes.
and it moved into the gay communities on the west and east coasts of the US.
And of course, it wasn't just, for sexual relationship. It was whether you had a blood transfusion or all sorts of things, unfortunately,
Well, it was
that
because
it did spread,
Exactly, because it's one of those things called a bloodborne virus. So when it hit the US, they had no idea what was going on. And then suddenly, after a few years, young men started getting sick and then dying with a characteristic group of diseases that were very, very suggestive of disturbed immune systems.
Right.
They get sort of unusual cancers or unusual infections. That was then the start of recognizing because none of these men had any reason to be immunosuppressed. They weren't taking large amounts of steroids. They hadn't had anti-cancer treatment or anything like that.
Otherwise, very healthy men.
Very fit and healthy men who looked after their health. And then they were dying in really quite larger and larger numbers.
Yes.
And then people started to get infected when they started looking for these characteristic diseases that constituted AIDS. Now, AIDS is an acronym, and it stands for Acquired Immune Deficiency Syndrome. So this was a set of diseases that were used for surveillance purposes to try and work out how this new problem, so-called AIDS, was spreading. So if you had one of these very unusual infections or cancers, you were labelled as a case of AIDS.
Yes.
So people were noticing this in people who were receiving blood transfusions.
Yeah.
And they were also, and particularly haemophiliacs, and they were also noticing it in a few Haitian immigrants. So you had the three H's: haemophiliacs, homosexuals, and Haitians.
I'm sure everybody can remember from that time that Princess Diana, of course, was such a wonderful ambassador for recognising AIDS as what it was.
And she was unbelievable in actually hugging an AIDS patient in the Middlesex Hospital in the late 80s at a time when everybody was so scared because they didn't know what this was.
Well, they thought if you touched somebody, you got it.
Yes.
It was incredible. Yeah.
And at the same time, that sort of stigma and discrimination was happening in healthcare services here in Australia, as people were just about trying to understand what was happening here. And of course, HIV was brought into Australia through men who'd been over to the US or South Africa or Europe and had encountered it in their from partners they'd had, sexual partners they'd had, who were infected unbeknowingly with HIV, because we didn't have a test for HIV in the 80s, early 80s or mid 80s. We developed it, and then that was then how it was recognized that the HIV was a global epidemic and that it was a particular problem in East and Central Africa.
But then we got on top of it, didn't we? Eventually, Charles, tell us a little bit now about the antiretroviral therapy known as ART, A-R-T. I mean, it's a combination of medicines that suppress HIV, isn't it, replication in the body, and enabling people with HIV to live long, healthy lives and prevents the progression of disease. And to this day, that's made a huge difference, hasn't it?
It has very slowly made a huge difference. So when I started working in the late 80s and then early 90s, my work was initially describing how you got sick with a compromised immune system and what you could do to try and stay healthy.
Yeah.
At that time, enormous developments were going on in the pharmaceutical industry and in universities to develop antiretroviral medicines against the HIV, human immunodeficiency virus. And these were called antiretrovirals because HIV is a so-called retrovirus, hence antiretrovirals. And slowly, individual compounds were identified that were effective, and then people put them together because it was recognized if you just had one antiretroviral, you got drug resistance very, very quickly. So they were put together in combinations, and that's combination antiretroviral treatment. And it was incredibly effective. But 2000, when AIDS was being transformed from a death sentence to a chronic and manageable disease, provided you took your medicines every day. Because these medicines didn't cure AIDS.
No.
They just suppressed the replication of the virus inside your body. So as AIDS was or HIV infection was being transformed from a death sentence to a chronic manageable disease, the drugs were incredibly expensive. It cost 15 to 20,000 US dollars a year just in drug costs, excluding any of the costs of the health services, any of the incredibly expensive high-tech investigations you need to have to manage people with AIDS.
So how did we then get to the stage where it is now affordable for many people?
So that's when the closing the treatment gap, as it was called, was declared a global health emergency.
Right.
And the UN declared it a global health emergency in a landmark UN General Assembly special session, so-called UNGAS, in 2001 in New York. And this was the first time an infectious disease, HIV and AIDS, has been discussed in the General Assembly of the United Nations. And at that time, it was recognized that the countries that were bearing the brunt of the epidemic, they were mostly developing countries, particularly in Africa, but also in Latin America and Southeast Asia. And they didn't have access to any form of treatment. So it was declared a global health emergency. And I then moved from the UK, where I was an academic and professor of tropical medicine at the School of Tropical Medicine in Liverpool, to the World Health Organization in Geneva. And I was supported by what were the UK government to go and work in WHO to try and work on care and treatment and to work out how WHO could somehow close this treatment gap.
Now, you're listening to Lots to Chat About. I'm Rosemary Peterswald, and my guest today is Charles Gilt, International Public Health Specialist. So now, Charles, before we finish with AIDS and HIV, tell me, how did the antiretroviral therapy become available to probably to everyone, isn't it?
There were several things here that we had to do in WHO as the technical UN agency in charge of health. The first thing was to simplify the treatment of HIV and turn it from something that could be done by nurses and clinical officers outside, specialist hospitals, which is how it was managed and looked after in Australia and in Europe and in North America. So we developed the public health approach to managing AIDS. And then we set up guidelines for how you diagnose it and how. Then the second thing was how we got drug costs down. And if I can spend a little bit of time talking about going back and reminding people that the UN had declared the epidemic a global public health emergency.
Yes.
Because of that, the trade-related international property legislation that was under the WTA, the World, whatever it's called, enabled countries to manufacture antiretroviral medicines without having to, under license, because the patent protection was taken away as TRIPS legislation was in the World Trade Organization, WTO, as that was put out. And so the treatment that had been unaffordable over a period of about 5 years became incredibly cheap. So going from 15 to 20,000 US dollars a year, we got treatment down with these sorts of approaches, and getting the generic companies involved around a simple formulary that we were promoting in our public health approach, got the price of drugs down to 150 US dollars a year.
Which is fortunately affordable. And then it changed AIDS from being a death sentence to, as we've said before, to something that you can live with.
Yes, because the treatment was available in cities, but also in rural areas, in health centres.
Yes.
And there were global financing mechanisms like the Global Fund and through the US government, PEPFAR, the President's Emergency Fund for AIDS Relief, one of the things that Donald Trump and his colleagues and Elon Musk have recently cut. So these funding mechanisms were supporting low and low middle income poor countries to buy the medicines and then provide them across the populations.
Right.
So we are now up to over 75% coverage of anybody who needs treatment. That's
Yes.
anybody infected with HIV, adult or child or pregnant mother,
Yes.
to receive these medicines. That is an amazing
It
public
is.
health achievement.
It is
And that's why we can say, sorry, I'm interrupting you, and that's why we can say we have really got on top of HIV.
Which is a wonderful achievement for worldwide.
It is. And the other development is that as these antiretroviral medicines were becoming more and more available, we started to think about how to use these to prevent transmission or prevent people getting infected. Exactly the same way as when you go off and you're going off to holiday in a malaria area, you take anti-malarial drugs as
Yes.
prophylaxis.
Absolutely.
So, and we were then working out how to use that. And the first group was pregnant women who were infected with HIV. We treated them so that the risk of them transmitting it to their unborn child was massively reduced. Then we started giving it to people who'd been exposed through needle sticks in hospitals. And then we started thinking about it for pre-exposure prophylaxis before you went off partying.
Right. Well,
It's been incredibly successful.
And
So
thank you to people like you that, fortunately, it is, as I've said a couple of times now, it is no longer a death sentence. It is something you can live with.
And in Australia, we've really got on top of HIV infection. So we don't see cases of AIDS. And, we really see very, very little transmission of HIV in at-risk communities, gay men, drug users, sex workers.
Which is
a fantastic public health achievement in Australia.
And absolutely, and worldwide. Now, talking of Australia, of course, Charles, you moved to Australia to be Dean and Head of the School of Public Health at the University of Queensland in 2013. But now, just to go on a little lighter subject, before we get on to that, I'm sure our listeners would love to know how you met your beautiful wife, Marina, who, to our listeners, is one of our magnificent presenters here at 4RPH Reading Radio. Am I right in saying you had some convincing to do of her very protective Greek father before you were allowed to be a serious suitor as this Englishman that wafted into their lives?
I most certainly had a few issues here. So I met Marina at university. Marina was at Cambridge along with me, and, we hit it off fairly well.
Yeah.
And then Marina came down to London when I was there doing my clinical studies, and she did the bar. And then she decided she had to go back to Cyprus because Marina's from Cyprus originally, and her father was expecting her to go back after she'd done her studies and go and work in Cyprus. So Marina went back, and then we sort of keep our long-distance relationship. And I finally got to the position when I said, well, this is ridiculous. I need to ask Marina to marry me.
Yeah.
And I know she won't mind me saying this. And she suddenly said, no, I can't. I can't leave Cyprus. My dad won't let me. So I was heartbroken.
I can imagine.
And at that stage, I ran off to Papua New Guinea for a year, as you do, because I'd been offered a job there. And obviously, there was a lot of tropical medicine in New Guinea.
There certainly was. You were there the same time. A little bit after.
I was there in 84, 85. And then I came back to the UK, and I went to Oxford, and I started work on malaria. Because, at that point, we didn't really understand how significant the AIDS epidemic was in Africa. We just thought it was an issue in gay men and blood blood transfusions and haemophiliacs in the West. So, and I came back, and then Marina phoned up one day and said, my father's died. And I said, well, that's awful.
Yeah.
And she said, well, do you want to come to Cyprus? And
right.
we can.
The barrier had disappeared.
Well, the barrier disappeared because, Marina's father was terribly protective of his daughters. He had 3 daughters.
As many fathers are.
He'd seen his other daughters marry and have long-term relationships with what he called foreigners, non-Cypriots. And it hadn't worked out well, and they'd all ended up in Cyprus. So he didn't want Marina to make that same mistake. And he was worried that if Marina married me, she'd be in the UK. Little did he know that we'd actually end up in Africa and then...
And in Australia.
And in Australia and Switzerland and in India, as Marina and I wandered around the world. And so I went over to Cyprus, and then we sat down, and I'm sorry, can I spend just a little bit more time? So and then Marina and I had a very pragmatic discussion, and he said, well, maybe we will get married and give it a go. Yeah. So I said to Marina, well, I better ask your mother for your hand in marriage. So I was ushered into their living room one afternoon, and I sat Marina's mother down and said, could we? I'd like to marry your. Would it be okay if I could marry your daughter? And she said no.
So the barrier hadn't gone.
No, it hadn't gone, because she really Marina was living with her and looking after her, and so she really didn't want me. So I went out and I said, hon, we've got a slight problem here. Your mother's just said no.
Oh, right.
So she went in, poured her mother a gin and tonic, and then that was it.
Right.
She said yes, and then we got married, and then...
And you came to Australia.
We came to Australia.
And... which I must say, Australia should be very grateful that you've both arrived here. Now, we are running out of time, Charles. Okay. It goes so quickly, unfortunately. But of course, now cancer is something which you and I, in fact, have both been affected by. There are great steps forward in treatment, but still no one has come up with an actual cure, have they? Do you ever see that happening?
Some cancers are considered cured. Right. Some of the childhood leukemias, for instance,
yes.
you hit those cancers really quite hard. And then some of the adult cancers as well are considered curable. You look at, say, breast cancer.
They're nervous to use the word cure, aren't they? You're in remission.
You're in remission, yes. But you're regarded as having conquered the cancer after you go 5, or in some cancers, 10 years down the line. They can always come back. So I'm 5 years into, or nearly 5 years into, my prostate cancer, and my, that PSA, that test that they do in the blood.
Yes.
I've been undetectable for 4.5 years. So I'm thinking I'm getting to that magic 5-year mark. And I think it's the same with you. You've done pretty well with your treatment.
I have, actually, and I am incredibly grateful to modern medicine, because I am 3 years. As our listeners know, I suffered from ovarian cancer. Yeah. But every day, of course, is a bonus. I never wake up without thinking, wow, here we are, another day. And but at our age, of course, I know you're younger than me, but at our age, any day is a bonus.
And I must just here say that one of the really important things is that some cancers are preventable. So you think about cervical cancer, it's prevented by vaccinating children with the papillomavirus vaccine, Gardasil. Great Australian development. One of my colleagues at UQ was instrumental in that. So the anti-vax movement is terrifically bad for cancer down the line, because people aren't taking, adolescents at school aren't taking up Gardasil.
That has been offered to them.
Been offered. And then there's another vaccine, globally, hepatitis B virus infection, which is preventable. And all healthcare workers in Australia are vaccinated mandatorily against, or they should be. And it's offered, and that protects against developing liver cancer, because the hepatitis virus goes chronic in a few people, gets cirrhosis, and then some of those people develop cancer. So not having a hepatitis B virus, HBV vaccine is crazy.
Yeah. Well, I mean, we have stepped so far forward, haven't we? Not only in AIDS, the treatment of AIDS, in malaria, and, as you've now said, in vaccinations for all sorts of diseases. Yeah. But, Charles, sadly, we have run out of time, because we might have to get you back again to talk about a bit more. But thank you very much, Charles Gilt, for being my guest today. Thank you, Paul, for producing.
Thank you.
And this programme has been produced and recorded in the studios of 4RPH Reading Radio in Brisbane for syndication around Australia, and will be available on YouTube at Lots to Chat About with Rosemary Peterswald.
great friends and great chats. That was another Lots to Chat About with Rosemary Peterswald. Stay tuned next week for another amazing chat.